Hey everybody, let's give everyone a couple more minutes to join and then we'll get started. All right, everybody, we'll go ahead and get started. I'm Dr. Stone. For those of y'all who don't know me, I joined Centennial Pediatrics last year, and I thought I would start doing these live Instagram Q&A sessions for a couple reasons. One, just to allow y'all who have not met me or seen me in the office to kind of get a feel of how I manage things, and also just to be helpful. I know a lot of times these are questions generally that I get asked by multiple parents, and so I thought maybe distributing my thoughts on them on a more widespread basis would be helpful. Anything I say tonight on these sessions, don't take as medical advice. Obviously, if you have a concern about your child, bring that up to your pediatrician. But with that, the way this is structured is I had people write in questions throughout the week, just general questions about parenting or pediatrics in general. I took the top 10 questions that I thought would be the most helpful or the most prevalent questions that people had, and I wrote them down on piece of papers, and I put them in a hat. So we'll just kind of randomly draw those questions out. I hope to get through all of them. Last session that we had lasted about 30 minutes or so. That's what I anticipate this one lasting as well. And then if people have questions, just questions that you think of during the session, you can go ahead and write those in. I'll ask for those at the end. I may miss them if you write them during the session. So if you think about a question during the session, go ahead and save it for the end. And then if we have time, I'll take a couple questions at the end that you'll run in. All right, with that, we'll go ahead and get started. Okay, first question. My baby has not pooped in 4 days. Is this okay? Yeah, so this is a question that I get a lot in the office. And so, the term constipation in kids changes as the age of the child changes. So typically when kids are babies, within the first month, they're pooping quite often, and they can poop with every diaper change. That'd be totally normal. And then it transitions to this a little bit different frequency. Typically after a month or two, babies, especially breastfed babies, will all of a sudden just stop pooping. There's a couple reasons for that. One is the GI tract that absorbs the actual nutrition in the milk just gets longer as the baby grows, so it takes more time for the food to go through the whole GI tract. And then secondly, the babies are growing so rapidly that they are absorbing everything into their body that they can. And so all the breast milk or formula that you're giving them, a lot of times they're absorbing so much that there's not a lot left to poop out. And so a baby that hasn't pooped in 4 days can definitely be normal. Now, obviously, that comes with a couple caveats. So as long as the poops are still soft and liquidy, and as long as the baby typically had a bowel movement or pooped within the first 24 to 48 hours of life, if those two things are checked, then yeah, it's very normal for a baby not to poop for 4 days. They can even poop or not poop up to a week or a week and a half, and that'd be totally normal. As long as one, they're growing, and two, they're not having hard, kind of rock hard poops, then that's normal. If that changes though, if they start to have kind of more harder poops, or they're really trying to push hard poops out, then you can talk about, should you be treating this baby for constipation? Most babies do have quote unquote trouble with pooping. This is called dyschezia. And it's not real trouble. It's really just them trying with all their effort to get poop out. And a couple reasons is they're still learning how to poop, right? They've only been pooping, a few days or weeks or however old the baby is. They've only been pooping for that long. And they really haven't formed the coordination of straining with their abdominal muscles and relaxing their sphincter. They haven't really learned that process yet. So it will take time for them to learn that. And as they get older and older, that becomes less and less of an issue. All right, next one. When should I bring my kid in for stomach bugs, and when should I just treat at home? That's a great question too. So obviously, especially kids who are in daycares or in schools, they are like little petri dishes running around, spreading germs at daycares and schools. A lot of kids will come in for stomach bugs. And so the good question is, when should you just be treating this at home, and when should you actually bring the kid in? And again, a lot with pediatrics, it depends on the age of the kid. So the first few months of life, if babies are really having, there's very much a difference between spit up and vomiting, which we won't get into. But if you're having like a stomach bug, you're having vomiting and just profuse poops in a newborn or in the first few months of life, that should probably be checked out by a pediatrician, just because babies are so little and fragile. Now, as they get older, as you get into the school age kid, kids will have vomiting and diarrhea. And honestly, it's much more reassuring to me when a kid comes in with vomiting and diarrhea than just vomiting. Just vomiting kind of opens up a can of worms of what's going on. But if you're having vomiting and diarrhea, 99 times out of 100, it's likely a stomach bug. And so reason or things to bring the kid in for, if you're having fever and vomiting, fever 100.4 degrees Fahrenheit or higher, and you're having vomiting, that should probably be checked out, just because there's a broader differential of what's going on than just a virus. If you're just having fever, or if you're just having vomiting, diarrhea, but you're not really having fever and the kid looks okay, then you can probably just treat that at home. Other causes to bring the kid in would be if the vomit looks like a strange green color to you. It's usually described as like a highlighter green or a dark green. That would be more suggestive of a little bit different pathology than just a viral stomach bug. So that should be checked out. And then of course, if you're not staying hydrated. So hydration status, again, the way to assess that changes on how old the kid is. And so if you're still in diapers, typically I look for about 4 wet diapers within a 24-hour period to know that the kid is staying hydrated. And as they become more potty trained and they become more school age, as long as you're urinating, again, like 3 to 4 times within a 24-hour period, you're likely staying hydrated enough to assess or to stay at home and just treat that with liquids and rest. And then in terms of the poop itself of reasons to come in, if that becomes bloody for some reason, then obviously that should be checked out by a pediatrician. All right, next question. What is your definition of a fever? What is the best thermometer to use? Well, that's a great extension from the last question. So a fever in the medical field is defined as 100.4 degrees Fahrenheit or higher, or 38 degrees Celsius or higher. And I have a lot of parents who use the forehead thermometers that I strongly recommend against. And just because I've been in so many situations where a parent will take, actually I can think of a situation that didn't happen very long ago where a baby's temperature was taken with a forehead thermometer and it said it was 102, and the rectal thermometer, or the temperature whenever it was taken via rectal temperature, was 98.6. And so obviously the rectal temperature is much more accurate. And so what I suggest is just getting one of the traditional under the tongue thermometers. Up to a year of age, I recommend taking a rectal temperature. And the way to do that is getting one of the under tongue thermometers, just put a little bit of Vaseline around the metal tip of the thermometer and then gently insert the metal tip into the anus. Let the timer go off, and that's your temperature. Now, after the age of 1, you can likely just take it under the tongue and be relatively accurate. but I strongly recommend against the forehead thermometers just because I've seen such wide variability with the temperatures that it outputs. All right, go to the next question. I see one actually right in. It says, how can you tell if it's a stomach virus versus food poisoning? It's a great question. You probably can't. One of the biggest assets in a pediatrician's arsenal is the history. And if you come in and you say, hey, we were at a picnic, the kid ate some potato salad and he started vomiting like 12 hours later and everyone's vomiting. Well, probably it's food poisoning. Or if you come in and say, hey, my kid's in daycare, everyone has a stomach bug and people are getting different illnesses like or the same illness but days apart, then it's probably a stomach bug. Now, it doesn't necessarily matter to an extent because you're likely going to be treating it the same way. And so that is, it is important to distinguish in the history, but at the end of the day, if your management isn't changing, it doesn't necessarily matter. And for people at home, whether you're deciding to bring the kid in or not, it really is based on the factors that we talked about earlier and whether you're able to stay hydrated or not. All right, next question. What are signs and symptoms of an ear infection? That's a really good question because even in the medical field, there is definitely some variability in the studies of what is the most suggestive signs of a kid having an ear infection, and there's definitely not a perfect answer. So it really, again, going back to the age factor, it depends on the age. Elementary school kids who are verbal, they can probably tell you their ear is hurting. And also as you get older, you develop less and less ear infections just based on the anatomy of the drainage systems becoming more vertical and gravity helping you out. Now, before kids are verbal, especially in like the 0 to 2-year-old range where they can really not express everything they want to express to you, biggest signs are one, ear pain is the number one quote unquote suggestive sign of an ear infection. But again, it's not perfect. There's a lot of kids that come in and will be grasping at their ears, and based on the developmental stage, they may have perfectly normal ears and they're just pulling at their ears because they are an infant and they discover that they have ears. They want to play with them. Fussiness in babies, fevers, especially all these signs in the setting of a kid having a cold. So it's pretty, I wouldn't say rare, but uncommon for a kid just to sporadically develop an ear infection. A lot of times what happens is kids will develop a cold, they'll develop all this mucus, the drainage system of the ears, the eustachian tubes will become blocked by the mucus. That allows for fluid to build up in the middle ear cavities, and that fluid is a great nidus for bacteria to grow, and that's what gets you your secondary bacterial infection. So most of what you're looking for, you'll usually have this pattern of, hey, my kid was sick, he had a cold for a couple of days, and now he has a new fever, or now he's pulling at his ears. That's a pretty common complaint that I get that's usually associated with an ear infection. Now again, every kid who complains of ear pain doesn't always necessarily have an ear infection, but especially ear pain in the older kid, fussiness in an infant, new fevers like a few days after having cold symptoms is suggestive of a secondary bacterial infection. And then I don't know if there's great evidence behind this, but anecdotally, I feel like when kids come in and they're super fussy when they're trying to be laid down to sleep, that is usually a sign that was either one, there's fluid in the ear, which can be sterile or not sterile, and then two, whether that fluid is infected. I don't know if anyone has ever studied that, probably not, but that's just anecdotally what I've seen as well. All right, go to the next question. What are your recommended allergy medications? So I took this as seasonal allergies. I'm expecting that's what they were asking and not like food allergies. So recommended allergy medications, especially in the springtime that we're about to start. A lot of kids will start having allergy symptoms, which can include like itchy eyes, runny nose, sneezing. sinus pressure. Most kids, usually don't develop allergies for a couple of years because it takes repeated exposures to these allergens to develop an allergic reaction by the body to them. So typically before then, it's usually just a viral infection. But afterwards, after a couple of years, your body sees the allergens over and over again. Your body starts reacting to them. And so what do? So there's a couple things you can do, and a couple things that I recommend to my patients, and actually I do them personally. So I was a kid who had really bad seasonal allergies growing up. I used to get allergy shots like 3 times a week. It was awful. I did that for years. So what I do now though is I take a Zyrtec in the morning. So it's cetirizine is the generic brand. And a lot of times I'll write out the generic medication for my parents in the office because 1, it's the same drug, and 2, it's usually a lot cheaper than the brand name. So children's cetirizine you can take in the morning, and depending on the age, you can either do like 2.5 milligrams, 5 milligrams, 10 milligrams in the morning. And then I usually start there. Or you can do like Claritin or Allegra or anything like that as well. They all work similarly. And then at night, if for some reason the morning medication just isn't getting it done for you, I'll add on like a nasal spray. And so I used to only recommend Flonase, which is the generic form is fluticasone propionate, much cheaper than Flonase, the brand name, by the way. It's what I use. And actually, I used to only do that, and then this new-ish medication came on the market called Astapro. So Flonase, or fluticasone propionate, is an intranasal steroid, so it just calms down a lot of the inflammation that's going on in your nose and decreases the ability for some of those cells that are related to allergies to release all their byproducts. And then Astapro is an antihistamine nasal spray. And so what I've been doing recently is, Flonase is great, but steroids themselves have a little bit of side effects. Intranasal steroids don't have that bad a side effect, but what I've seen in my personal life is I was using Flonase all the time for years, and my septum started to wear down a little bit. I was developing a little bit more nosebleeds and a little bit more pain in my septum. And that can happen with steroids in terms of thinning of the septum, and also it just doesn't allow the body to heal all that great. And so if kids are starting to run into that issue, or if they need long-term nasal sprays, what I'll do is I'll tell them to do Flonase for a month and then switch over to Astapro for a month, and then just go back and forth. At the same time, keeping that children's cetirizine/Zyrtec or Claritin or Allegra in the morning. All right. And then if for some reason that's not working, at that point I've kind of run out of tricks, and then I'll usually send them to the allergist to assess if they need allergy shots or not, which I hope not, because when I was a kid I got those for years and that was not fun. They were helpful, but just not fun. All right. Next question is, what is the deal about tongue ties? That's a great question, because I'm not sure a lot of people, even in the medical community can define it. So it's become this more recent fad. There are, I would say, most pediatricians believe in what we call an anterior tongue tie, which is essentially, it's just called ankylosglossia. It's the frenulum on their tongue that attaches it to the roof of their tongue is a little bit more prominent. Babies who may have trouble latching, or they may have trouble breastfeeding, especially if the mom is having a lot of pain, that can be what we call quote unquote clipped. A few providers in our office do it in the office. Some of us send them to the ENT docs. And so that can be helpful in terms of, not latching well, mom is having pain, you do the what we call frenulectomy or frenectomy, and then all of a sudden the kid is latching great and the mom is not having pain. Now, with all these quote unquote tongue ties I'll talk about in a second, there's not a lot of great evidence that they're super beneficial. So when I talk about evidence, I talk about the actual medical journals, scientists who are studying these things in large populations. So not like, hey, my friend went and got the kid's tongue clipped and all of a sudden their life was changed. This is like hundreds and hundreds of patients being evaluated to see if there actually is a difference between 1, doing a frenectomy and 2, doing nothing. Now, there's a lot more support with pediatricians about doing the anterior tongue tie, and so that's what we'll do in our office as well, is just clip the frenulum if we feel like it's necessary. Now, there's this recent fad of a posterior tongue tie or a lip tie, and that has even less evidence than the anterior one. And you'll likely find in our practice, and I would guess most pediatricians across the country, don't even really understand what a posterior tongue tie is because no one's really defined it, or whether or not clipping the lip tie is beneficial, because everyone has you can use the word lip tie, but really just a frenulum that attaches your upper lip to your gums. So that is much more physiologic than what I say pathologic. So you should have a lip tie because if you don't, then something probably didn't form super well in your lip. It doesn't necessarily mean it needs correction. Now, you will find people who do like clip the lip tie. And, anecdotally, I've seen a couple moms say, hey, yeah, it was super helpful, but there's just not great evidence to support in large scale that it works. And so what you'll find with our practice, and like I said, with most, the anterior tongue tie can be addressed, but the posterior tongue tie, which I still don't even understand what it is, and the lip tie, I don't usually recommend doing anything about, because it's a probably painful procedure for the baby, and I'm not sure it has a ton of benefit. All right, next question. What are symptoms of UTI in kids? This is a really good question too. So again, going back to the age thing, this is why pediatrics is so fun. It depends on the age. So obviously older kids, elementary school kids, even toddlers who are still wearing diapers can tell you, hey, something is painful when I'm peeing. Or in elementary school or high school, or say, hey, it really hurts when I pee. That's pretty obvious. Now the kind of art to all this is, how do you decide that a 9-month-old has UTI? And so sorry, 1 second, guys. Need more. The 9-month-old, it really also depends on the history on the kid. So girls within 0 to 12 months are much more likely to develop UTIs than boys, especially circumcised boys. And then really after 1 year, if you have a boy developing a first-time UTI, that would be pretty abnormal and would probably require a little bit of a workup. It can happen, but it just would be a little bit strange. But in terms of the infants, what are the actual symptoms? So fever, especially outside of a kid having a virus. Now, if a kid comes in with a runny nose, nasal congestion, cough, and they have a fever, then likely they have a virus or a secondary bacterial infection like an ear infection, or God forbid they have a pneumonia or something. But if a girl or a little infant girl or even an infant boy comes in, under a year and they just have fever, I would be a little bit more on high alert that they have a UTI. Now, they can definitely just have a virus, but a fever that's unexplained with other symptoms probably needs to be assessed a little bit closer than just saying, oh, they just have a virus. Also, another symptom is if the baby has such a bad UTI that then they can actually start vomiting. And so if you have like fever or vomiting in a less than 12-month-old who doesn't have any of the like typical viral, like runny nose, nasal congestion, cough, I would be like very, very suspicious of UTI. And like I said earlier, it's a little bit of an art because, how do you diagnose UTI? Obviously, you have to get a urine sample. And depending on the age, that can be tricky. So 0 to 12 months, usually is done by a catheter. So they put the catheter in the infant's urethra and into the bladder. They pull out the urine, they pull the catheter out. We look to see if they have an infection. Kids who are potty trained, usually 3 and above, can usually pee in a cup for us. What's really more of the art is the 1 to 3-year-olds, because you don't really want to have to cath those kids because they're big and strong and they'll fight you. And so also they have a lot more cognition of what's going on. And so that's just not a very fun thing to do. And so you can have them, and what I've done to some degree is they can pee in a bag for us. They can pee in like a cup that sits on the toilet. You just have to take those samples with a few more grains of salt because it's not really like a clean sample. So that's more up to the discretion of the physician treating you, and that's where the kind of art of medicine comes in. Sorry, I feel like that was a little bit of a tangent, but that was an interesting conversation. All right, so what over-the-counter medications do you recommend for colds? Above the age of 6, typically those kids can get all of the cough medications of the world, the mucolytics of the world. So you're talking about children's Mucinex. You're talking about even Robitussin, your DM products above the age of 6. Under the age of 6, or between 4 and 6, you're usually looking at more of just your mucolytics, so your children's Mucinex products. You know, you can technically give your DM products there, your dextromethorphan. Those are actual cough suppressants. You'll find that most pediatricians are much, much less excited to give those medications the younger the kid gets, because there's been studies in the past that, especially under the age of 2, the DM products increase mortality rates in children. And so obviously we're not going to give anyone under the age of 2. And I'd say they're still not super popular between the ages of 2 and 6. Your children's Mucinex is good for 4 and above. Like I said, your DM products are good for 6 and above. So what do you do for your under age 4? There's not a ton between the ages, or 1 and above. You can actually use dark honey. Honey has actually been evidence shown to decrease cough in kids by just soothing the back of the throat. You can find that in your Zarbee's over-the-counter cough medication. You can also just get spoonfuls of honey from the pantry, the dark honey. That's what sometimes that would do with our kids. Under the age of 1, unfortunately, there's not a lot. So it's your nasal saline and suctioning if you feel like the runny nose and the congestion is causing the cough. You could also do your humidifiers. You can do steam showers. You can do the baby's Vicks Vapor Rub above the age of 3 months, and then you can use regular Vicks Vapor Rub over the age of 2 years. So unfortunately, under the age of 1, it's just not very fun because there's just not a lot you can do for them because you can't have honey under the age of 1 for the risk of botulism. But especially after the age of 6, you have a lot more options at your disposal, but kind of under that, you become a little bit more limited. All right, next question. Is there a connection between autism and vaccines? Wow, yeah, that is a big question. One that we are definitely not going to go into a lot of detail here because that is more of like an hours-long conversation than a 30-minute conversation. Obviously, being a pediatrician, I believe in the evidence that they don't cause autism, but I know that's much more of an emotional conversation, and I get that. As being a dad, I don't want to just brush off parents' concerns and be like, oh, they're fine, you know, like I get the emotional connection there. And so what typically I recommend to parents, a good place to start at least, as I feel an objective entry point, there's a couple books that are very, very well written by 2 great communicators, both doctors. However, one actually has a daughter who has autism, was diagnosed with autism, and he is probably the most prolific vaccine developer in the world, especially when it comes to the underdeveloped countries. His name is Peter Hotez. He was actually a professor at the medical school that I went to, Baylor College of Medicine. And he is a phenomenal doctor and a great dad. He has a book called Vaccines Did Not Cause Rachel's Autism. I'll say that one again for people who want to write it down. Vaccines Did Not Cause Rachel's Autism. It's a very, very poignant read that not only talks about the medicine, but also talks about just being a dad to a child who has autism. And then there's another great book called Autism's False Prophets. I'll say that again, Autism's False Prophets. That is another great book written by a doctor who kind of looks at the evidence and the history behind it. And again, I'm not going to go into that because that will take a very, very long time. But that is a great entry point for parents who have concerns. I usually recommend them starting there. All right. Let's look. So this is our last question, it looks like. And I think I saw another one about adenoids. Let me see if I can answer that real quick. If adenoids are enlarged in 5-year-olds, is it worth removing, or will it reduce in size as they get older? That depends. So it really depends on the symptoms of the kid. If you're having just recurrent sinus infections, typically what I see, now obviously I'm not an ENT doc, so if you have concerns for your own kid, you should talk to them. Typically what I see, they'll usually start with an intranasal steroid, like the Flonase we talked about earlier, see if that improves your symptoms, and if it's not, generally they'll take them out. It's not a just one size fits all answer, but that's generally what I see ENT docs do. But if you have concerns for your kid, just reach out to your pediatrician or ENT doc. This is our last written question of the day. What are your thoughts on Lil Mixins versus Spoonful One? Yeah, so people who don't know what this is, Lil Mixins, well actually let's start with Spoonful One. Spoonful One used to be, I'll say used to be because they've actually stopped production in the US a month or two. It was very recent, a couple months ago. And so they had these powders essentially that had super high allergenic food. So your peanuts, your other tree nuts, your eggs, your shellfish, all this stuff, like the proteins of those things mix into a powder. And as your kid was starting solids, you would introduce these things on a frequent basis. And the reason behind that is there was a study and multiple subsequent studies called the LEAP trial, LEAP, LEAP. And so what this showed was 3 times a week peanut butter, the earlier you introduce this, the lower chance that your kid will develop food allergies to peanuts later on. And so there have been subsequent studies to study other foods, etc. But their Spoonful One is like, what the heck? Let's just introduce 30 of these high allergenic foods at the same time. And so that's, that's a double-edged sword. So yeah, it's great. It probably does reduce the chance that your kid is going to have food allergies to those specific foods later on. But also, let's say you introduce those, or you do a Spoonful One sample, and then your kid has a reaction to it. Well, what exactly did he or she have a reaction to? Because you introduced 30 at once. And so what I typically recommend is whenever I start talking to my parents about introducing solids, I actually first I recommend, hey, just introduce like something new, like every 1 or 2 days. And then I do recommend just putting a little peanut butter either on your finger or on any other food they're eating, and just let them eat that 3 times a week. 3 times a week was the frequency they studied in the LEAP trial. And then I'll also ask them to do like chopped up scrambled eggs into really small bites, like 3 times a week. It depends on your pediatrician. I generally recommend babies starting solids at 6 months. It's definitely not wrong to have them start at 4 months if they're developmentally appropriate, they have good head control. There have just been some studies in the past to show the earlier you introduce solids at 4 months, the greater chance you have of developing a higher BMI later. Now, those studies were by no means perfect. Definitely there's association before 4 months, but typically with those studies, I usually say, hey, just wait till 6 months. Now, you're probably missing a slight window of the earlier introduction of the high allergenic foods, but, I still think it's worth a little bit of a wait. and just sticking with breast milk or formula until 6 months. As far as little mix-ins versus spoonful one, again, you can do little mix-ins. They're still producing in the U.S. as far as I know. However, I saw them advertise on their website once that somehow it was more cost effective than just introducing like pantry foods like peanut butter and scrambled eggs like I talked about. And maybe they're right. I just can't comprehend that because I feel like we buy so much peanut butter at our household that it would just be like giving your baby a little bit out of that can, or eggs. But maybe so. I don't know. Anyways, I would just recommend doing like I said, peanut butter or scrambled eggs. You can do the little mix-ins if you want to go down that route. It's essentially the same thing. But there definitely is clear evidence to show the earlier you introduce it, the lower chance that your kid will develop food allergies to those specific foods later on. All right, guys, so that is all the written questions beforehand. Does anyone out there have any other questions that they want answered that we can talk about? I'll give you about a minute to write those in. It looks like actually someone entered one in the question box. Can at-home COVID test be used on toddlers? Probably. So it depends on what COVID test you're using. I don't think there's any recommendation against an age to use those. Now, what I'll say is, do you need to be doing that? It just really depends now on the ever-changing landscape of COVID quarantine rules. But if you ever have a question, you can give our office a call and we can hopefully guide you in the right direction. All right, guys, any other questions before we end the session? I'll give you about a 30-second warning. Shout out to my wife for bringing me water because my throat was getting dry. Okay, I got one. How early is too early for boys to start puberty? Great question. 9 years old. So boys should start puberty between 9 and 14 years old. By the textbook, the first sign of puberty in boys is an increase in testicular size. And then girls should start puberty between 8 and 13 years old. First sign will be breast budding. All right, guys, any other questions? Give you about another 30 seconds. And I'll try to do these about once a month. I felt like we got a pretty good response the first time we did this last month. And just from the numbers I've been seeing while we've been live, they've been even higher tonight, which is great. I'm glad this could be helpful. So I'll try to likely do this again next month. Be on the lookout for a post on our Instagram page. I'm much more of an Instagram guy. That's just the generation I grew up in. I think it links to our Facebook posting as well. But please be on the lookout. And if you have questions, please go ahead and write those in next time. I'd be happy to answer them. But if we don't have any more questions tonight, which I don't see anymore, we'll go ahead and call it a night. But thanks, guys, for joining us. And it was my pleasure. And if you have any questions that you think about later, feel free to call our office and our nurses will try to help you. And if they can't, one of our docs can help you too. All right, guys. Good to see y'all again, and we'll see y'all next month.